Okay, so I only have 10, 15 minutes, but I try to cover a very wide topic, how we advance in the identification of patients who have high risk in long-QT syndrome.
We're ahead of time, so you can have 5 more.
Any case, yeah. So we advanced beyond assessment of just simply looking at a patient, what the QTC is telling, if it's 500, 550, you have a high risk. If it's 350, you have a low risk. We advance beyond that, and I want to incorporate this type of how we relate to sex hormones, the age, and the risk stratification, and the genetics and the mutation type. So we'll start with providing some background for all of you. I guess some of you know about the background of long-QT syndrome, how we assess risk by looking at clinical markers, the genetics, possibly within the genotype, there are certain mutations that convey a higher risk. They are more predisposed to arrhythmias. Then sex-specific risk stratification in long-QT syndrome, which is very important, how it interacts with age, and possibly the mechanism, how sex hormones affect the risk of arrhythmic events in patients with long-QT syndrome. And Dr. Akhtas is going to focus subsequently on oral contraceptives and which types can be used and what types of LQTS genotypes can be used in this population. And the management implications. Again, if people can mute while others are speaking, it would be helpful because there's some background noise. So again, background. We know that up until today, the number is increasing. 17 identified LQTS genotypes have been identified, more than 500 mutations. Most of them are still LQT type 1, type 2, and type 3. They convey most of the cases that are genetically diagnosed. And each one of them is associated with a different pathology. So this is not one disease. Long-QT types 1 and 2 are associated with a reduction in the potassium current. I'm not going to go to the specific mechanism, but long-QT type 3 is associated with increase in sodium current. So each one of them conveys a different clinical scenario. One of them is associated with exercise. The second is associated with acute stress and anxiety. The third one, events even occur during sleep. So those are different diseases, and we have to remember that. But in the past, about 20 years ago, when Dr. Moss and Dr. Schwartz established the diagnostic criteria, everything actually relied on the clinical scenario, on the QTC, the morphology of the T waves, the EKG, a history of events. That was for the diagnosis and the family history. That's the way we identify patients with long-QT syndrome, not by genetic testing. And when Dr. Moss and I wrote a review article about 15 years ago, we relied mostly to identify high-risk patients based on their QTC and the history of events. That's it. Not on genetics, not on mutation, not on age, and not on sex, and not on sex hormones and their effects on outcomes. But we've advanced beyond that, and today, genetic testing allows us to identify even carriers of long-QT syndrome, even about 25 to 50% of the patients in which QTC appears to be normal, but they still have a pathologic mutation. And this has therapeutic implications. On the other hand, we have to remember that about 1/4 of the patients who undergo genetic testing may still have long-QT syndrome, even though they are genetically negative. So we have to remember that there are some limitations to genetic testing. And see how important it is, because once we identify the gene, we can also look that the gene expresses differently for specific patients. For example, if we look at the EKG of patients with long-QT type 1, we see that the T waves are very tall, like a tent. In long-QT type 2, the T waves appear like biphasic. In long-QT 3, the T waves are delayed. So the expression of the disease is different by the type of gene. And this also relates to the triggers of cardiac events. As I mentioned, in long QT type 1, most of the events are triggered by exercise. In type 2, by emotional stress and arousal, like an alarm clock at night. And long QT 3, the events unfortunately occur even without a warning during rest or sleep. And Dr. Zariba was the first to publish in his New England paper the fact that the genotype also affect the risk of events. So we see long QT type 1 events occur the highest risk of cardiac events, but the highest risk of lethal events occur in patients with long QT syndrome type 3. We advanced beyond that, and today we know that the risk within each genotype also relates to the mutation, location of the mutation, because, for example, in long QT type 1, the CLOP mutations that modulate the adrenergic activation are associated with the highest risk. And we see that long QT syndrome type 1 patients with CLOP mutations have the highest risk of lethal events from birth to age 40 years. And now, when everybody undergoes genetic testing, we can also look at the type of mutation, and we can know specifically how to better treat patients by the type of mutation, because you see that those specific CLOP mutations are more likely to respond to beta blockers. Wow. And this goes the same for long QT syndrome type 2, where the pollup mutations convey the highest risk. And also, we see that in patients with long QT type 2, the highest risk goes for patients who have a pollup mutation. And also in patients with LQT type 3, we see that the highest risk is associated with certain mutations as opposed to other mutations who have a low risk. Okay.
It has to be from that.
From here.
Yeah, she's higher than.
There
There we go. There we go. There we go.
Okay. Okay, thank you. So we also see that even in patients who have a normal range QTC or have a genetic diagnosis of long QT syndrome, patients who have a high risk mutation still have a high risk of life-threatening cardiac events that can result in avoided cardiac arrest or sudden cardiac death. And this is the reason that genetic testing is very important, not only to identify the genotype, but also the type of mutation that can be treated differently. And I will touch on that as well. And we have also advanced beyond the fact that only the QTC is important. We also know that there's an important age and sex interaction in the risk of long QT syndrome. You see that during childhood, boys have a high risk of cardiac events compared with girls, but after the onset of adolescence, there's a risk reversal, and women have a high risk of life-threatening events compared with males, and this is because of the effect of sex hormones on the ion channel that I mentioned, especially the potassium channel that is associated with long QT syndrome. And based on that, I'm not going to expand, but we have identified risk prediction models, especially during the time of adolescence, in women and in men that are specific during this time period that relate to the type of mutation, the genotype, but also incorporate specific QTC, whether the mutation is a PO region, non-PO, CLOP mutations. And based on this, we can know during adolescence what the risk would be. 14%, 5%, 2% during 10 years after the onset of adolescence. And this is specifically for women. And you see that the highest risk is after age 15 years. And we better risk stratify patients with long QT syndrome by knowing the genotype, the type of mutation, the QTC, the history, and the sex of the patients, of course. and this is the risk of life-threatening events. And we also recently developed a similar models for male patients, especially adolescent boys, because we see that also after the onset of adolescence, there's a high burden of cardiac events. So incorporate the same methodology to incorporate a sex-specific risk, and this is for boys after the onset of adolescence, showing high, intermediate, and low risk for cardiac events after the onset of adolescence. So what could be the mechanism of the effect of sex hormones in the risk of long QT syndrome? We see that this is the cardiac activation of the heart cell in patients with long QT syndrome, and we see that sex hormones have an effect on all those stages of the activation. And as I mentioned, in most patients with long QT syndrome, there is a reduction in the potassium current. But estrogen appears to further reduce this. So increasing estrogen is more likely to increase the risk. But progesterone and testosterone have an opposing effect and possibly increase it. So this may actually reduce the risk of cardiac events in long QT syndrome, so that there's interaction between sex hormones and the ion channel in patients. So in boys who have increasing testosterone after the onset of adolescence, this may be actually protective and reduce the risk. And in women, the ratio of estrogen to progesterone is very important, because if there's a higher relatively concentration of estrogen compared to progesterone, the risk may increase, whereas the opposing effect may protect women with long QT syndrome. And we see here what happens. This is actually the ratio of estrogen to progesterone during before and after pregnancy. And we see that women after giving birth have the highest risk of cardiac events. And why is that? Because during pregnancy, the ratio of progesterone to estrogen is high. But after giving birth, the ratio of estrogen increases and progesterone goes down faster. So the risk of cardiac events is actually increasing. So this ratio of progesterone to estrogen is very important. And based on this, and using the collaboration of patients in our registry, we have recently studied the correlation of sex hormones and what happens during and the risk of cardiac events during the menstrual cycle in women with congenital androgynous long QT syndrome in our registry. And in this study, women in our registry took levels of sex hormones during the menstrual cycle, and we had 7-day ECG recording cycles to look at the QTC. And as you see, as progesterone levels decline, there's a reduction in QTC. And as the progesterone to estrogen ratio, progesterone levels increase, there's a reduction in QTC. And again, as the progesterone to estrogen ratio increases, there's also a reduction in QTC. So during the menstrual cycle, after ovulation, the progesterone ratio increases and the risk of QTC increasing is also reduced. And this is all what happens also when we get drugs that mimic long QT syndrome. So our findings show a genotype-specific correlation, especially in women with long QT syndrome type 2, in which hormone changes during the menstrual cycle may affect propensity for cardiac events, especially in women with long QT type 2, but also in women with long QT type 1. And this has also important implications how to treat our patients, because if we look at patients who have a high risk, especially, for example, we take patients with LQT1, who have serious mutations, males after the onset of adolescence, or women with LQT2, we can initially give them the appropriate beta blockers, especially non-selective beta blockers. This is very important at the highest dose. Then we can go for a second stage of left cardiac sympathetic denervation, or for some additional medications that are available today, like mexiletine, pacing therapy, And only at the end, as a final result, we can offer our patients an ICD. So in conclusion, what I try to convey here, that long QT syndrome is not a single disease. We should incorporate when we assess the risk and we treat our patients, not only the QTC, but the genotype, the specific mutation, the age of the patient, sex, of course, before adolescence, after the onset of adolescence, the symptoms, whether the patients are syncope on and off beta blockers, the time-dependent QTC may change over time. We should remember that the beta blockers is the mainstay, but we have to mention to everybody, we have to stress that the optimal dose should be obtained. And there are specific types of beta blockers because beta blockers is not a single drug, and there are types that are more appropriate for our patients. And each and every one of you needs to know that they have to be treated with the optimal drug. And then we can still incorporate genotype and mutation-specific risk stratification. And only after that, as a final result, ICD therapy.
Thank you very much. I see that we have some additional questions, but we will hold with the question after the next two talks. And so we have some other